Welcome to the Smart OB-Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it.
Welcome to the Advanced Learner Series. I'm Abigail, one of the fifth-year General Internal Medicine residents, and I'm joined here by two panel experts to help go through with my case. The first expert is Dr. Janine Malcolm, an endocrinologist and associate professor and clinical investigator in the Department of Medicine at the University of Ottawa. She's the vice chair for quality and patient safety and director of equity, diversity, inclusion, and accessibility. She is a leading expert in the care of patients with diabetes in pregnancy and has contributed nationally as a member of the expert committee for the 2018 Diabetes Canada Practice Guidelines, amongst many other accomplishments. Welcome. Our other expert is Dr. Erin Keely. Dr. Erin Keely is an endocrinologist at the Ottawa Hospital and full professor in the Department of Medicine at the University of Ottawa. She is a former president of the North American Society of Obstetrics Medicine, is a past chair of the Canadian Diabetes in Pregnancy Interest Group, and co-author of the Diabetes Canada Diabetes in Pregnancy Clinical Practice Guidelines. In recognition of her contribution to the medical care of pregnant women, she received the North American Society of Obstetrics Medicine Lifetime Achievement Award in 2019. Her research, which has resulted in over 200 publications, is focused on health service delivery and provider-to-provider communication, in particular e-consultation. So welcome. We'll dive right into our case, if that's okay. So this is a 31-year-old female, G2T1A1L1, of South Asian ancestry, normal BMI, healthy previously, diagnosed with gestational diabetes after a 50-gram oral glucose tolerance test showed a glucose of 14.3. She did go on to get a 75-gram oral glucose tolerance test with values of 7.6, 15.6, and 16.5. She was counseled by the diabetes nurse educator and dietitian and seen in the special pregnancy unit. She was started on MPH, which was titrated up to 12 units twice a day. But given that she had ongoing postprandial increased sugar hyperglycemia, she was started on aspart insulin 3 units 3 times daily with meals. Her prior HbA1c was 5.7% 1 year prior to pregnancy. She has a family history of type 2 diabetes and obesity on both parents' side. She presented in labor but was later delivered via C-section due to failure to progress at 38 plus 1 weeks. So when screening for gestational diabetes, what do you usually recommend?
So if you're screening at the typical time of the 24 to 28 week window, which is different than screening in first trimester for someone at very high risk, in Canada, the recommendations are 2-step tests, so a 50-gram. And if it's normal, then no further testing. If it's above 11.1, diagnosis made. And if it's in that gray area, then you go on to the 75-gram. There are some jurisdictions that use just a 1-step and go directly to the 75-gram, but most would do the 2-step testing.
And so in this patient, would I be correct in saying that she was diagnosed with gestational diabetes at the 50-gram test? She didn't technically require the 75-gram.
That's right. So she was above the threshold for needing to do a 75-gram.
Okay. And let's say that she had an HbA1c of like 6.1% a year prior. Would her screening change with, say she actually had preconception counseling or something like that? Like, would you handle her differently?
So you would screen in first trimester rather than at the 24-week mark. The test you do in first trimester is debated because the 50-gram and the 75-gram isn't standardized for first trimester. So it's standardized for second and third. And there's so many changes that happen in pregnancy with glucose metabolism, you can't assume that the cutoff should be the same. So many will use a hemoglobin A1c in first trimester as opposed to the 50-gram screen. But even that, there's some caveats. And you're really looking for, did this person have diabetes before they got pregnant? So an actual pre-gestational diabetes.
So this patient was followed in a special pregnancy unit postpartum due to having some elevated sugars that were ongoing after delivery. At follow-up, her sugars were in the range of 5.6 to 10. So lifestyle recommendations were made with a plan for a 75 oral glucose tolerance test between 6 weeks and 6 months postpartum. So what do we typically expect glucose readings to be postpartum in a patient who had gestational diabetes?
So usually your glucose in general tends to revert to normal in most people. Long-term, gestational diabetes really is kind of a predictor of your progression to long-term diabetes, and depending on the population that you're looking at, can be 20% or more within sort of 10 years of the index pregnancy. So in her case, I wouldn't say necessarily in her case because her oral glucose tolerance test actually was quite high. So that actually makes you worry a bit. And she did have ongoing hyperglycemia after delivery, which also makes you worry a little bit. Usually once the placenta is out and that insulin resistance, drops quite dramatically, their sugar should generally normalize if it's what we call a more of a let's say classic gestational diabetes, or that more mild diabetes that occurs only that we see in pregnancy.
And so what are you worried about when you don't see this normal glycemia postpartum?
Yeah, so, gestational diabetes really is really defined as first onset of recognition of diabetes in pregnancy, but it's a catch-all, right? Mm-hmm. So the person could have type 1 diabetes, she could have had preceding type 2 diabetes. You do probably worry most about type 1 diabetes because of the life-threatening implications, right? So if we miss it and she's not diagnosed, if she develops DKA and becomes very ill, we want to make sure we kind of, rule that out. So that would probably be the most important thing.
Yeah, the other thing that goes against her being type 2 diabetes is that she did have a normal A1C a year ago. So that would be unusual, not impossible, but unusual for someone who had type 2 diabetes to have a normal A1C a year prior. You would expect them to at least have a pre-diabetes A1C.
Mm-hmm. And so in these people that you're very concerned about, let's say that like this patient who has ongoing high sugars, are you still going to follow that standard protocol of the 75-gram oral glucose tolerance test at the 6 weeks to 6 months, or would you be approaching this differently?
So you only need to do the 75-gram glucose tolerance test if they don't have a diagnosis of diabetes. So if she has a diagnosis of diabetes based on other criteria, such as an A1C, fasting glucose above 7.8 or a random above 11.1, more than 2 of those, you don't need to do that screening test because you already have a diagnosis of diabetes. So in general, for the person who does not have persistent hyperglycemia, you're really looking for that risk of type 2 diabetes later and did they normalize. But if you already have a diagnosis of diabetes, you don't need to further screen them.
So in this patient's case, the infant had medical issues, and so she does not go perform her oral glucose tolerance test. However, around the 4-month mark, she's actually admitted to hospital and is found to be in DKA. The C-peptide is measured and is on the lower limit of normal, and her anti-GAD antibodies come back elevated, and she is diagnosed with de novo type 1 diabetes. So would you characterize her as having latent autoimmune diabetes in adults, or LADA, or would you say that this is more of a type 1 diabetes de novo type picture? I know that's a bit difficult to, I know it's like the same
so
thing.
It's pretty much a continuum.
Yeah,
so there is an autoimmune component. And, when you say classic type 1, people often think about, the person was well, and then immediately all of a sudden then they weren't well. But probably what had been happening in the background is they probably had been having sort of this, damage in the background. People with the LADA, sometimes it's more of just a prolonged presentation. They may be like that for years actually, and not progress. So again, it's a little bit difficult in this case to say for sure, but I would say, the fact that she had seemed to have been coping, I guess, for lack of a better term, for quite a while without any, insulin per se, then probably she may have had a bit of a LADA type presentation, and then, finally got to the point where her islet cells were not enough to keep her out of ketosis.
Yeah, she's not LADA now because she's got it. So those 4 months, I agree, you could if you had done her antibodies then and she was not yet in DKA, but she was hyperglycemic, you could say she's probably LADA.
Yeah.
But once she presents as full-blown type 1, you would shift the diagnosis. And people with LADA often get misdiagnosed as type 2 diabetes because they're hyperglycemic, but they're, as you said, is prolonged. Nothing, quickly happens to them, which is a little bit different than her as well.
And this, again, might be another hard question to really truly answer, but out of interest, when people have autoimmune diseases and there can be that phenomenon where they can get better for temporarily in pregnancy, and then after a period of time, they can get sometimes a resurgence after a period postpartum due to kind of the immune system almost flaring back up. Could there be any, could she have had an underlying autoimmune destruction of her pancreas that then got worse at postpartum, or is this really just related to the pregnancy burning it out?
That's hard to say. It's probably a bit of both, to be honest. I mean, the insulin resistance in pregnancy probably accelerated things maybe a little bit. Hard to know, like her demands are higher. So maybe her reserve maybe gone out a little bit quicker. I don't know if anyone who's actually really done any C-peptide or any kind of studies looking at before and after.
There is evidence that you can regenerate some beta cells in pregnancy as well. So there are women who who know you have type 1 diabetes and remain off their insulin for a short time postpartum without going into DKA. The mechanism of that, whether it's related to the immune suppression of pregnancy, I don't know, but it is a phenomenon that people can produce some C-peptide that shouldn't be producing C-peptide. So usually the autoimmune destruction isn't an immune surge like you see in those first 3 months. It's good. There had to have been something else going on for longer than that.
Now, to just kind of tie it all together, for clinicians in the future, they have a patient who had gestational diabetes, postpartum, sugars remain elevated, they don't have a diagnosis firmly of diabetes. How should they approach these patients? What would you recommend to them?
So if they don't have the normalization of sugars while still in hospital, really should be, that 24, 48 hours that they're normalizing. Then and it really also is other risks. So what's the whole package, right? If she has some risk factors for type 2 for sure, no risk factors for type 1, I would have assumed that she was going to continue to have type 2 diabetes. Mm-hmm. But you need to coach them on if this gets worse, right? If their sugars are rising quickly, if they're feeling unwell, then it's a urgent call. When to do a C-peptide and or an anti-GAD antibody really would be on gut. This person shouldn't have type 2 diabetes. Mm-hmm. This person doesn't have risk for type 2. So we have to be worried about type 1, remembering that type 2 is so much more common. So we wouldn't naturally do antibodies after a pregnancy unless it really was quite remarkable hyperglycemia or didn't have any risk factors for type 2.
So Dr. Keely, can you summarize a few key take-home points for the learners listening to this?
Yeah, so I think the main take-home point is that if hyperglycemia doesn't resolve postpartum, women need to be followed and treated for diabetes. I think the distinction between what type of diabetes really is usually a clinical decision, not a DKA. They come in sick with DKA, so you hope you can make that distinction. And I think, if you really don't feel that this is typical type 2 diabetes, to think about type 1 and do the testing. But I think most importantly is give them a lifeline to call. So if things aren't going the way that they anticipate, to make sure that they remain connected with the medical community. I'll also just throw out that even women without a sick baby often don't do their postpartum screening. Mm-hmm. So it's incredibly hard for women to go and do a 75-gram glucose tolerance test at 6 months postpartum. So that would be my other, I know a little bit deviated from this case, but most women it's going to take up to a year to do that. And we need either to remind them or their family physician about the importance of getting it done.
Thank you both so much.